Welcome to Trying to Conceive with Dr. Sasha Hakman, where we break down the science of fertility, share real patient stories, and explore the latest innovations in reproductive medicine. My name is Dr. Sasha Hakman, and I'm a double board certified OBGYN and reproductive endocrinologist and infertility specialist. I practice at HRC Fertility in Beverly Hills, but this podcast is an independent project created and hosted by me separate from my clinical work. Don't forget to subscribe so you never miss an episode. And if you want exclusive updates and resources, be sure to sign up for my newsletter. Just click the link in the episode description. All right, today we're going to talk about the psychological impact of infertility on couples who are facing and struggling, trying to conceive. And today I have an amazing guest, Dr. Sarah Oreck, who I've been following you on Instagram for a while. I love your page. You put out amazing content. Sarah is a mother of 3 children. She is a Columbia University trained and board certified psychiatrist with a fellowship in reproductive psychiatry, and the co-founder and CEO of Mavita Health, as well as the medical advisor for the FDA-cleared Natural Cycles fertility tracking app. She is driven by a deep frustration with the shortcomings in maternal mental health care, and Dr. Oreck envisioned Mavita Health as a platform to revolutionize access to high-quality mental health services throughout the path to parenthood. As a practicing therapist and prescriber, she combines cutting-edge medical treatment with a holistic, whole-body approach to mental health. She is the daughter of South American immigrants and grew up between LA and Colombia. She currently lives in LA with her husband and 3 children. And I love the little piece of you being the child of immigrant parents, because so am I. Yeah. I really feel like it really shapes who we become.
I'm not surprised we're doctors.
Yes, exactly. They definitely ingrain it in us as children.
Exactly.
So obviously we know that there is such a psychological component to struggling with infertility, and I really want to take a deep dive into all of it. I see a wide range of reactions to different diagnoses, recommendations for treatments like IVF as you're navigating the treatment, dealing with failed treatments. But before we get into all of that, I really, really want you to share your story because I feel like it's a really impactful one, since you've had your own experiences that I think really can help in the care that you provide.
Oh, absolutely. What's interesting is that I did this before ever having those experiences. So I got to learn a lot from my patients before I went through them. And even though I thought I knew everything and what to expect, like, it still threw me for a loop. So
I bet
no matter how much you know, how much you have kind of talked to people, it can still be really hard on an individual level.
Totally.
So for me, I decided to have babies during the pandemic. And so I had my first 2 boys spontaneously. Didn't have that much difficulty. Amazing. And then things kind of took a turn. I wanted a third, though I'm an only child and I don't know like how I came to have 3 children, but here I am. And we actually decided it was taking a little longer, but we had a baby and we had a significant genetic abnormality and had to have a second trimester termination for medical reasons.
Oh, I'm sorry.
And it was the hardest thing I've ever gone through.
I can't even imagine.
Like a desired pregnancy that's taken a while, and then to find out that this is what's happened is catastrophic. And this is why any kind of ending of even when you do, even when you're not sure about whether you want to have a child or not, and you have a termination, it's an excruciating decision. But I was really privileged to live in a state where that was still allowed.
Yes.
And my quality of life and the quality of life of that child that was unborn, who would have, global issues, right? They would be intellectual, physical. I mean, this child's life was going to be in a hospital.
Yeah.
And I had to think about how that would affect my 2 older children.
Totally.
And what our life would look like. And I just couldn't see myself in that life, though I know some other people can. Yeah. And so I think it's all about, let's respect each other's choices. But there was a lot of shame too.
Oh, I can't believe that, because the beauty is in choice, right? We don't all want the same things in life. And so that's a big deal. It's already hard enough to process.
Oh, yeah.
That loss, especially because the reality is when we get to the point of pregnancy, your mind's already picturing the baby and the milestones.
And it was a girl. I had 2 boys. I mean, the fantasy that I had projected onto what this would be like, she had a name, everything was sort of, I had projected what it was going to be like to have this family of 3 children. And I just think it's really important to remind people that these are not easy decisions for anyone, but they're decisions that we should be entitled to make. Mm-hmm. So anyway, that happens. It kicks me for a loop. And actually, this is around the time where I knew I wanted to start Mavita Health. I had been kicking around the idea for a long time. I was in a private practice, felt like I didn't get to serve enough people because it's out of network. I'm only one person, and really felt like, after having this experience, I wanted a specialized provider, which I didn't have, and it was so hard to find.
Wow.
And mind you, I have colleagues, I have resources I could have paid out of network, and yet the waits were so long. I had to basically beg for favors to see someone who was highly specialized. And I thought, oh my God, if I'm having this difficulty and I am literally in this field, what are other people doing? And when you have a loss, my doctor was like, well, I don't do these D&Es, but you can go over here. And it was like, bye. There was no follow-up. There was oh,
that's brutal.
There was nothing. There isn't that much holding in that time. And sometimes that reminds me of fertility stuff.
Yeah.
There isn't that much holding of let me check in on you. Let me see how you're doing. And so it's kind of okay, you have the loss and then you're out, and if you get pregnant again, you come back. And that's just not enough. And
it's not enough.
We really need more support during that time because, again, this is crushing. It happens to so many people. And yet when you're the one that's grown that baby, fetus, whatever you want to call it, and other people haven't in your life, I felt like my husband couldn't really connect with the loss like I did. It's just different. I had been so physically sick. She was living inside of me, not of him. And so I think I felt really isolated, and that's why I wanted that specialized care. But anyway, this is a long-winded way of saying that then I went into fertility treatment. I really wanted to make sure that we kind of got the outcome that we wanted, more control over things, that's a whole other subject. As much as you can, because you really can't control things, even with IVF.
Yeah.
And we had a good experience, but it was still challenging. I was still very am I replacing what I lost? Yeah. What's happening here? Do I really want this? It was a lot of kind of trying to understand, and what my values were and what was important to me. We ultimately did end up having a baby girl. Aww. She's 14 months.
Congratulations.
Thank you.
But that's exciting.
It was bittersweet.
Yeah, I'm sure.
And I don't think that much time goes by where I don't think about this other loss that I had.
Totally.
So it's really interesting when we have, non-physicians sort of twisting what terminations are like. Mm-hmm. People just go and get them. And they're like, okay, all right, on to the next one. Right. You carry this your entire life. Even if you were 20 and you did not, you were not planning to have that baby. Every time I see a patient and they talk to me about that termination, that decision, it's heart-wrenching.
Yeah. Yeah.
I wasn't ready for a baby, but it's still something that stays with me.
Yeah. Yeah. I think that's a very normal sentiment and not surprising.
Yes.
And I'm sorry that you endured that. It's so hard because I remember with my first pregnancy, which was from IVF, I had an embryo transfer. At 8 weeks, I started bleeding really heavy. And before I got my scan, I was seeing patients and I'm trying not to cry because I'm thinking that I'm losing the baby. And I was 8 weeks. By the second trimester, you're just sort of
it's happening.
This is a full human. You're showing you.
It's my third pregnancy, so my uterus was huge.
Yeah,
right?
and it's not it makes the loss of a first trimester any less. No. It's different because you think that you're sort of
you've made it.
You've made it.
You've made it.
Yes.
And then the worst part that I think not many people know about is if you have a loss after 14 or 15 weeks, your milk comes in.
Oh my gosh.
And then how cruel it is to have all this milk coming in with no baby.
Yeah.
Right. That I think was really poignant. But, in some ways you turn these losses and this grief into something for me was, one of the loves of my life, which is Mavita Health.
Love that.
And that has been really worthwhile. And I got to experience what many of my patients had. And then having the IVF journey, I have very low egg count. My mom had very early perimenopause.
Wow.
So I think I'm headed that way.
Yeah.
So I also got to kind of understand what it's like to take the shots, not that I did just for that, but it's been really nice to have worked with all of these people for so long and then get to be in their shoes really and have that experience. Yeah,
totally. When you first found out the diagnosis and had to make these decisions, how did you process? What tools did you use to kind of get through that?
I think certainly talking to my partner was very important. And I think we had talked about before, which I think is so important for everyone, as you're building a family, to make sure that you are aligned and even talk about what your values are. What's important to you? What kind of life do you envision for you and your children? And we weighed what it would be like this. We read all of the papers of what do these children, what do they need? What do their lives look like? Their lifespans were very short, right? And that I was already that is so hard to contend with, right? I mean, obviously you wish that you would not outlive your children, but the fact that there's a likelihood you will is was just too hard for me to conceptualize. And I think together we were able to come to this seems like a decision that's right for us. It is not easy. It is extremely painful. I can still imagine what it might be like to sort of be this caretaker and have this other child. Mm-hmm. But ultimately, this sits right. This was the right kind of path for us. And we've always valued quality of life over just life.
Totally. Yeah.
This gets into a lot of things. I'm very interested in end of life. It's interesting. I'm very interested in the beginning of life and the end of life.
The end of life.
Those are sort of my passions in medicine. And so for me, there's something tied to that, right?
Mm-hmm.
Life has to be what we value, what we want. There's some, I do think that there's some fates that are worse than death sometimes.
Agreed.
I know that's a little spicy, but I think life at all costs. And when we've done rotations in ICUs, where people are just sort of and doctors are just, and oncologists are so forceful about, hey, let's just do this and do that, and let's do this chemotherapy, and people aren't living.
Totally.
Right? That's we're going off topic, but yes, that's something I'm passionate about.
Off topic, but also there tends to be this trend in women's health too, where quality of life is very ignored. And that also matters for fertility patients. Yes. Patients dealing with infertility and fertility treatments. Yes. As a fertility specialist, I'm always trying to think of the decision I'm making for this patient, the recommendation I'm making, how is this going to affect their quality of life? Yes. And is there something I can do to improve that?
Yes.
Because patient satisfaction
about shots?
Those suck.
Those suck.
Those are terrible. But yeah, I mean, we're always, even at HRC, we're always trying to find ways to sort of improve the satisfaction, whether it's less injections or shorter treatment course to get to the same outcome. Yes. I think it's really, really important because, you put your body through so much just to get to a baby. Much.
And I think what you're getting to is when you're struggling with fertility or fertility issues, it can be as painful psychologically as going through an oncological diagnosis. That means a cancer diagnosis.
Yes.
I mean, that is tremendous amount of psychological burden. So if you can alleviate that by meeting the patient where they're at, kind of understanding what their lifestyle is and what will work for them, I think that's huge.
That is huge.
And so much of what I found is fertility clinics have such high volume that it's really hard. And sometimes people feel like they get lost in the mix.
Yeah. Yeah. You may not get enough time to ask your questions, not enough touch points with the doctor.
Right. But also, I think there's this idea that the doctor who isn't specialized in mental health should hold all of this for you.
Yes.
And I'm sure that you struggle with, since you're psychologically minded, like wanting to kind of help in this
struggle
way.
With that. Yeah.
But I think in some ways it is underestimated, the rates of depression and anxiety. We think they're around 50%, but I think that's a huge underreporting. I would guesstimate that it's more like 75% of couples that are dealing with fertility issues that likely have depression or anxiety diagnoses. And to me, that means there needs to be other support.
So let's use that to sort of segue into, in your practice, what have you noticed in terms of the psychological impact that is most pronounced in couples who are dealing with infertility? And how does it differ between male and female partners, particularly in heterosexual couples?
Oh, it's difficult, but I think we'll make some stereotypes here of what I see more often. You know, I think what starts to happen is that sex and intimacy and closeness has become kind of a vulnerable spot. And that's really hard for people who are in a romantic relationship. When you weren't able to conceive spontaneously, sex now has like this different tone to it. Yeah. And I think that's one thing that starts to happen, but also that there's so much that's placed on the female patient, right? On the woman, that they're the one that has to do the shots, that go to all those appointments. And there's so many.
There's so many.
How do you, it's hard to like have a full-time job and like go to all the appointments that you have to do, or like the shifting around or having to tell your boss that you're doing that is really challenging. And so I think there's where there starts to be this like imbalance of the invisible load in fertility treatment is really on the female patient. And I think that is reflected in other parts of the invisible load when people then go on to have kids. But here we see it very early on, where I think it's important to kind of start to get on the same page, figure out what your shared goals are. I think sometimes maybe one partner wants children more than the other. So then it feels like one is really sort of goal-oriented and focused on that, and the other's like, wait, like, can we be a little bit more flexible, or is this needed? So getting on the same page about like, what do you want and how do you get there? And then I always like for the male patients, can you go to more appointments? Can you be the one that's doing the shots, or at least like has a reminder in their phone to tell their partner to like, hey, let's do this shot, because that way it doesn't feel so isolating.
That's really helpful for guys to know how they can support their partners. Because if you can't physically be doing the part, then that's a big deal to at least alleviate some of the mental load. And
and there's so much, like we were just talking about.
So much.
It seems like you would never forget a shot like this, but I remember being like, oh my God, I need to go do this. And it's a lot to carry on your own, especially when you have other kids or you have a job and other responsibilities. So I think that's a really easy, pragmatic way to say like, hey, you're going to be in charge of talking to the nurse with me, having the schedule, translating to your phone, and reminding me.
Totally. And we were just talking off air before how, I had a patient who just forgot to take her shots yesterday and had to remember this morning to take it, which is not ideal. But I can't even judge, because having done my second IVF cycle post kids, life just happens. You forget things, even if you don't have kids, when you're in this brain fog of infertility and possibly work and life and the emotional turmoil that you're dealing with. It's nice to have someone sort of take that lead and say, hey, it's time for your meds. I got you. I set everything up. I lined it up for you. Here you go.
I'm going to help you. Right. And I think the other part is, if you're finding that you're foggy in that way, I think that's a really good indication that you're underwater, that you're already overwhelmed, that you need support. Whether this is kind of tapping your community, whether other people in your life have had similar fertility issues and can kind of be like, I've been there, like that peer support. But I think it can escalate to like having a therapist, having a couples therapist, potentially being on medication if that's something that's appropriate. But I do think that the therapy piece is so important, because there is this sort of mind-body connection when it comes to fertility. We don't totally know if it's the chicken or the egg.
Totally.
And people have had, are able to conceive in like wartime and high stress situations, but also those high stress situations, right? It's is this kind of maybe impeding some of the things that we want? Of course, we don't have those answers yet, but I do think if you're able to kind of be in a better state of mind, you're going to remember the shots. You're not going to be as anxious at appointments. Like, things are just going to feel better.
Absolutely. And I do sort of anecdotally notice that those who have a really good support system seem to handle it a lot better. But at what point...
And it's a roller coaster.
It is a roller coaster.
One day it's great. The next your cycle is going to be canceled or whatever it is. You know better.
And, looks like I have a lot of eggs. Right. The fertilization rate wasn't great. Right. Oh, no. But then you have a good number of embryos. And, there's always different things that happen throughout the course of your treatment that sort of gives you a little unwanted, unpleasant surprise. But, I always try to say to focus on the final outcome, because we don't know what's going to happen until it's done. But, therapy has definitely become a lot more popular. And I think that is such a beautiful thing, that there's less shame around it. There's less, you're labeled as crazy or something wrong with you just because you're seeing a therapist. What are the different types of therapies that people can access, and when do you recommend one versus another?
Well, there's so many different types of therapies. And what's really interesting about this is that some have more evidence base to be kind of targeted to certain populations. So at Movita Health, for example, we use something that's called acceptance and commitment therapy, which is a type of cognitive behavioral therapy, which is really focused on like values, on kind of how to really reorient what you're thinking about and not letting it be like this. Because we have a lot of automatic thoughts that sort of become like what we tell ourselves, but we really can disconnect of like, that's just a thought, right? That doesn't have to be who I am.
Yeah.
And so really what it's meant to be is really accept situations that are difficult. Kind of the loss of control that happens in fertility in some ways is like what we treat in a lot of ways, right? That you don't know what's going to happen at the end of it. And you kind of have to stay in that moment, and about being able to face things without distracting ourselves. We often numb ourselves through substances, shopping, scrolling on Instagram, whatever it is. And this therapy is really about like, let's start to confront those difficult feelings, because that's part of life too.
Yeah.
It's not just joy. Without kind of being on autopilot. So this has really good evidence in this population in sort of the transition to parenthood. And I want to say, even if you don't have kids, if that seed is planted, if you've frozen your eggs, to me, you're on the path to parenthood, because you've envisioned that there is a time in your life where you potentially want to be a parent.
Yes.
So that's really, and like, I think everyone who's going through fertility, even if you don't end up having a live birth, you've been on the path to parenthood.
I love the way that you frame that. I never even thought of it that way.
I think people feel really disenfranchised sometimes of like, well, am I a parent? Am I a mom? And like, if you're doing a million shots and you're getting embryo, like, yes.
Even for the possibility of a child.
Yes, that's exactly right.
Absolutely. At what point in somebody's course with you do you start to really, I guess in the beginning, you're always, I'm sure, screening for different things, but what are the red flags? I guess I'll put it that way. What are the red flags that you are looking for to say, you know what, you may not realize this, but you are in fact dealing with anxiety and or depression?
So particularly during fertility or at any time? Yeah,
particularly during the course of infertility or pregnancy loss.
Yes.
Particularly recurrent pregnancy loss, where every time there is a positive pregnancy test, it does not end well.
I know. And that's we've had that experience in sort of caring and holding space for those patients, which can be really challenging. So some of the red flags for depression, the biggest is if you feel like life is not worth living, and if you're having thoughts of not wanting to live or of ending your life, that is an absolute emergency, right? Your life has meaning. And I think it's really important to say this, because sometimes as someone who's had a whole business and career around motherhood and becoming a mother, you can have a really meaningful life and not have children.
Absolutely.
There's a lot of grief if you've wanted them, and that doesn't happen. But I think we mother in all sorts of different ways. We mother our friends. We can mother our nieces and nephews. Like, there's a way to have that kind of feeling and expression that doesn't have to be with having children. So if you think that life isn't worth living because you're not able to kind of achieve this goal, then I think that's something it's so important to talk through, because you can get to the other side of it, though it is difficult and there's a mourning process, of course. For depression, if you're not getting out of bed, if you're not functioning, right? If you're not seeing your friends, if you're not doing the things that give you a good quality of life, then we have to kind of figure out what's happening. Yeah. Anxiety, it's the same thing. And you probably know those patients. If you're calling a lot, if you're forgetting when the shots are, if you're like constantly seeking reassurance from everyone around, is this going to happen? That's a good sign. And I think the functioning for me is the biggest piece. If you feel like your worry is kind of crossing into anxiety where you're not able to do the things that you enjoy, where it is just like taking over your life, then it's time to kind of get more resources. And that's what therapy is. That's what medications are. That's what like community and peers are. It's just like adding things to your toolbox, kind of like how you all add something to the recipe, add this shot, add this thing. Yeah. That's what I like to think about. These are just tools that you can use, and you're choosing to use them. It's a choice. It is made out of strength of like, I can see that I need a little bit of support here, and this is what I'm going to do. It's like your IVF doctor saying, right, you need, I don't know, Lupron here, or you need, what are some other meds? Like, it's not trying to stigmatize you. It's not because you're weak or you can't, right? It's because this may help you a little bit.
I love the way you put that, because when we add on a medication, if I'm going to up your dose of Gonal-F, for instance, that's just a very matter-of-fact thing.
Right. I'm not like, oh my God, this must mean that I'm a failure, that I need a higher dose of Gonal-F. Like, no. I mean, of course, people already feel like something's wrong with them if they're an IVF, but this is like a nice way of illustrating when it comes to physical health, we don't kind of doubt or say, I don't know about that.
Right.
Are you sure I need more meds?
Right.
Right. I'm not sure about that medication. But, for psychiatric meds, there's still a lot of stigma.
Lots of stigma. And I face this with patients all the time. I'm on such and such medication. Can I continue? Should I stop? Or even patients saying, I want to be able to stop this before pregnancy for the sake of the baby. Yes. So when it comes to pharmacotherapy to manage anxiety, depression, how do you sort of help select the patients that have come to a point where they need medications? How do you select the meds for those who are trying to conceive for the safety of the pregnancy and postpartum?
Well, you said anxiety and depression, but actually let's think about all of the psychiatric kind of issues. So that's ADHD, that's bipolar disorder, you name it. And what's really important is that there actually aren't that many medications that are contraindicated, which means that are completely forbidden during pregnancy. So this is really interesting because we hear all these different things from the community, from community practitioners. I think, unfortunately, this is a small data set in the sense that it's all kind of based on case studies and reports. So a lot of because we weren't allowed to kind of have pregnant patients in randomized controlled trials, and women weren't in trials here for a very long time. And so what happens is that this niche of psychiatry really is not something that's taught at all medical schools. It's not something that's taught at all residencies. So a lot of people that are graduating, and certainly that have years ago, have no idea what's safe and not. The studies are out there though, and there's hundreds of millions of patients that have been on these medications. And that's really exciting. And from some of our Scandinavian countries where they keep really good records, they're able to see patient A was on this medication. This is what happened to their birth. This is what happened to their baby 18 years later. So we do have really good evidence for this. But I think what's hard is that, OBGYNs have so much to learn. And sometimes this isn't part of what's integrated into their practice. And so you'll hear very mixed things from different people, but there's only one medication that's not allowed, and it's called Depakote. People are on it as a mood stabilizer, sometimes for bipolar disorder, sometimes for schizoaffective disorder, and that's it. Every other medication has a great deal of nuance. Not to say that I'm be on all the medications. It has to be a risk versus risk decision. So for example, someone who takes stimulants because they're a lawyer who wants to work 20 hours a day instead of the normal time, that's not the most compelling reason to continue a stimulant. Right. But if you have ADHD and you can't drive without getting into an accident,
totally
that's a more compelling reason, because your life is literally at risk. You can't function at work. You can't function in your relationships. So it's really about seeing the patient, their history, and understanding, does this make sense? Because I think what we don't talk enough about is that there's risk to untreated mental health issues. So people are always talking about like the medication and what it's going to do to baby. Guess what? If you're not treating your depression or anxiety, for example, you have an increased risk of C-sections. You have an increased risk of preterm delivery. There's actually other neurobehavioral issues your children may have that are independent of your genetic issues. And so those all together, there's actually an increased risk of preeclampsia. So all of those things together make me think, like, let's talk about those risks for you. Like if you're constantly having panic attacks, maybe we should think about those risks versus the risk of being on medications.
Yes.
And of course, the things that we always go by are older medications in reproductive psychiatry because we have more data. So we don't like the fancy new meds. And then that helps with pre-authorizations for me, which is something doctors hate to, prior authorizations, which is what doctors hate to do. And so we look at old meds, low doses, but the most effective dose. Because there's no point in taking a very low dose and not treating your symptoms. Absolutely.
That makes sense. And even the American College of OBGYN, which is sadly, you know, they have an amazing practice bulletin on psychiatric medications and management of psychiatric illness and pregnancy, which is great. I will say, admittedly, that in our OBGYN training, that's usually the extent of it. And so we get to read a 10 or 15 page bulletin with practice recommendations, which doesn't leave us feeling equipped as experts by any means. So this is where we always will consult psychiatry to help us out. I think
that makes sense.
And it absolutely makes sense.
What's hard is when the psychiatrists haven't been trained.
Yes. When there isn't that aspect of the women's health and pregnancy, trying to conceive, that whole world.
Because, so much of it, and I think some of even the bend towards why I did reproductive psychiatry is I saw some of the best psychiatrists. I did my residency at Columbia, which at the time was like the #1 psychiatry program. Saw the best psychiatrists in the world have no idea what to do when they saw a pregnant patient. They're just like, Zoloft? I'm like, what? You guys have the right? Like you've written all the papers on all these other things. And this is like the one thing that you say. It's more nuanced than that. So for me, this was where I was really passionate. But I mean, it's another example of like women's health and mental health has just like not had enough research, enough data, enough education in medical school. And I think this is a prime example of how we talk about, we kind of like ignore mom and just think about the risk to baby.
Exactly.
And they're really, it's two patients, right? It's not just one. And I think that extends to like the feeding stuff that we've seen in the postpartum, this pendulum swing to you must breastfeed.
Yes.
Sometimes ignores the needs of the mother. And the fact remains that the best indicator of what baby is going to be like and what's going to happen to baby and that baby is going to thrive is that mom is doing well.
Totally. Yes. I think people really forget that. And this is why if you have a mother who is in poor mental health during her pregnancy, there's a higher risk of adverse events happening in the pregnancy and for the baby.
100%.
And so it's really, really important to manage these things, you know, ideally before pregnancy occurs. If things get exacerbated in a pregnancy, which they can be due to hormonal changes and physical changes and all the other things that come with it. And then, of course, we all know postpartum. Postpartum is a crazy time. And even if you have really great mental health, you still can end up with postpartum depression. It's way more common. I think it's way more common than what we're even
like
quoting.
The 1 in 5. I think it's more like 1 in 3, frankly.
Yeah, it almost feels like at least 75%. I just can't. I don't know many women that didn't experience it.
And I think that's more like the systemic issues. There's so many stressors on parents right now. And so I think it's probably certainly increasing. And I think it's so important to remind people who have gone through IVF or assisted reproductive technologies that they're at an increased risk. I always tell the patients that have been off, your pregnancy has been 6 years long. from the moment you tried and you couldn't get right, like that is a really long time to hold. And you are more vulnerable to those postpartum symptoms. But it's so hard because you're like, well, I had this baby's a miracle. I can't have any of these thoughts or feelings. I must be ungrateful. And so that's a challenge. But I think it's important to lay the groundwork. And if you're in treatment while you're doing the IVF, you're just setting yourself up for success in the future.
Which is great. I as we're having this conversation, I'm like, man, I feel like I should be sending all my patients to get that psychiatric support as they're going through treatment, because I think sometimes we, especially as women, don't ask for help when we need it. And we feel like we're inconveniencing others in that we're not able to make it work when we should.
Oh, 100%.
And if I can't even get there now, how am I supposed to, if I show that I have any sort of weakness right now, how am I supposed to show that I can mother in the right way? Which I think is just all very false thoughts, and that we are doing a good job, but we could do a better job at changing the narrative. Socially and culturally, and changing from the sort of individualism culture that we have going on to more community-based. And I know in other cultures, the well-being of one person affects the well-being of everybody else, and they look at themselves as a unit and not just as an individual.
I think that's why mothers are suffering so much in this country. We've kind of been told, hey, go do this on your own. Go find your child care. Go figure out how to cobble together a parental leave. Those are great examples of like how we're just kind of left to fend for ourselves. And here you have these huge stressors. But I love what you said, because I almost feel like, could you imagine someone who's going through like chemo and has an oncological diagnosis, like a cancer diagnosis, not be in therapy? And we just said that fertility is more psychologically painful than that. What? Right? It should be part of it. Well,
and even and not just infertility, recurrent pregnancy loss.
All of those.
That's a really big one, because you are dealing with so much grief from so many losses.
And there isn't like a consistent thread with your doctor, because you're just told, hey, you had another loss.
See
you again
really,
sometime.
It's really tough. And then the worst part is, even for those of us who do a lot of hand holding, it sucks knowing that in at least 50% of cases, I can't even give them a diagnosis. We do the full workup and everything comes back normal. And so I tell these patients,
well, that uncertainty, right? What is it called? What is it? What's that diagnosis?
Unexplained infertility.
Yes. Oh, sorry, I still have word finding difficulties here.
No, it's unexplained infertility is a whole different beast, because seemingly everything looks normal. Good sperm, good eggs, you're ovulating, tubes are open, normal uterine cavity. What is going on?
And I think that is, but even the naming of that, right, feels like it misses the patient experience. And it's not our, the nomenclature is not your fault, but like, it's almost like, I think even in how we soften the terms, communicate these things, you have unexplained infertility. It's just like, what does that mean?
Right.
How, who's going to explain it? What's going to happen?
How do you fix that?
Right. It's like, these names sometimes need to hold more space for the people that are actually experiencing it.
Yeah, absolutely. How would you say that when couples are dealing with infertility or pregnancy loss, how do you keep that? And this might be a little bit off from your field, but how do you keep that connection when you're both sort of grieving and possibly in totally different ways?
I think, well, first of all, we do have couples therapy at Mavita Health, because we think this is so integral to the path to parenthood. I also think it's important that we see fathers and men, and non-birthing parents. So whether you're the non-birthing partner or you've had a baby via surrogate or adoption, you can have all of these types of feelings. As you're in an adoption process, that can certainly be the case. As you have someone who's carrying your baby, is outside of your body, is maybe outside of your state, that can a lot can come up around there. And so how to keep the couple together, or how to kind of talk about these different experiences, I think it's hard, but open communication from the beginning is really important. But some couples aren't doing that already. And that's where I think there can be an intermediary. And I think couples therapy can be so helpful because there's an objective party that kind of says, hey, here's what I'm seeing, and here are some tools. It's like, who doesn't want tools to improve the way that they communicate with their partner? And I think there's a lot of communication breakdowns. There's a lot of misunderstanding. There's a lot of, I don't understand your experience, and vice versa in the fertility process. And that gap can really be bridged by that. You can obviously start by just like sitting and being like, hey, how are you doing?
Yeah.
I'm having this experience. I'm feeling like the shots are making, they make me feel crazy. I'm really alone. You know, can you help me with X, Y, and Z are like good ways to kind of start. But, you know, it can be really hard, especially if that's not something that's part of your kind of language or how you communicate with your partner.
And I'm sure that there's, in many cases, a lot of resentment that starts to build, particularly, I would imagine, if the women are physically taking the brunt of treatment.
Oh, 100%.
When, let's just say, there's male factor infertility and they're doing IVF for that reason, but she has to do the injections, has to undergo the egg retrieval, the transfer. And so I'm sure you deal with this a lot where it's like, well, it's your fault, like the blame game. Right. It's your fault and I have to do all of this. How do you even navigate that without creating massive turmoil?
I know. It's really challenging, but I think that's where you can get to like the core and underneath it. You seem overwhelmed about how things are, but together, here's what we want as a couple. We want to have a baby. Yes, sperm is the issue. But this is how we have to do it to be able to achieve this. So how can you have your partner help you? Because ultimately, if that, you know, like, I think the resentment is built from probably feeling like you're not doing enough. How can you help me? And there are many other ways. You can still take the shots and still feel really supported by your partner.
Totally.
Maybe it doesn't have anything to do with shots. Maybe they're really disorganized, but maybe they're doing other parts of the care. If you have other children, maybe they're picking up some slack there. Maybe they start doing all the cooking. Maybe they start doing all the laundry. You know, there are ways to kind of lighten each other's loads. And I think that is something that's really important in this. But I think if you do not talk, you very easily get into the like, oh my God, it's your sperm and I'm doing all this work. What a loser.
Yeah.
Like, why did I marry you?
Yeah.
And so I think that can be really tricky, and it doesn't have to get there.
Yeah.
Don't let it get there. And you're going through IVF because clearly the two of you love each other enough to want to go through all of this.
So true.
But I think what happens is that there's a lot of physical stressors, financial stressors, right? These things can cost so much. Or even if your insurance pays it or pays for a part of it, it's like, I mean, it's a whole gauntlet with your insurance company to try to get that money back. I've done it myself, but you just have to be persistent. That's all you have to do. But you know, there's so many stressors layered on top, and like your relationship may not be used to that, right? It may be used to dealing with like, okay, maybe someone got a new job or you moved a new city, but they used to be just like one stressor at a time. When it comes to IVF, things just kind of like all hit you at once. It's a lot at the same time. Same with parenthood, frankly. And so it just kind of strains the relationship more than other things have in the past when you're single people. Yeah.
And what I will say, especially being on the other side of infertility, being, you know, a parent.
Yes.
It only gets harder once you have the kids. I mean, it's the best thing ever. It's such a big blessing. You're grateful, you're happy. But I feel like if you don't tackle these issues in your partnership, they will only grow. They're not going to go away once you have a baby.
Right.
Because
toddlers and young elementary school students will get you, and then teenagers will, you know, I think there's so much there, but I agree. For me, they feel like a different quality. There's still something about having my body back and like mine.
Yes.
That feels really good. And like, I am not under as much stress, so I'm able to cope in different ways. But of course it's different for everyone. But yeah, I do think the communication skills, if you really want to stay together, right? We have such a high divorce rate in this country.
Yes.
And I don't think it's because, people are more incompatible now than they were before. I think people have a lot more choices now, including women are able to have economic independence, which is great. But I do think that there is this element of like, if we just kind of talked and figured out, are our values still aligned? If they're not, like, that's fine. You don't have to stay together. But if they are, just learning how to kind of bridge those gaps before they get so big that there's just no kind of bringing it back together, I think is really important. And that's why I think couples therapy is not for when you're at the breaking point. It's when you're going through stressors and you want to learn communication skills. But so often, and I think it's because it's high cost, difficult to find, people are like, okay, we're getting a divorce, so let's go into couples therapy. Yes. No, you can do it more preventatively.
Okay,
And that's why that's why Mavita Health and I've been so passionate about getting insurance coverage, because once you have that,
that's amazing.
Getting more people in, I think is phenomenal.
Yeah, that's really amazing, because I have noticed even here in LA, and I'm sure it's like this everywhere, so many people no longer take insurance. It's all cash pay, which is a barrier to access. And particularly with fertility treatments, while I definitely feel that insurance is responsible for covering infertility treatments because it is a disease that literally nobody chooses this.
Yes, nobody.
Nobody wants to do this.
Right.
Yeah. So if you are having to do any form of fertility treatments, just like all other forms of treatment that insurance covers, they should cover this too. But that's a whole different beast of a topic. But, for us in our field, our biggest barrier is access to care, primarily not even geographic, it is financial.
Yes.
There are other physical, geographical barriers.
Limitations.
Of course, but financial is the number one. And so same with mental health, when the majority of mental health providers are only wanting to take cash, and I get it. Insurance is a pain in the butt.
It's so hard to negotiate with insurance, especially as a single provider.
Yeah.
This is why, and that's why in my private practice, I never took it. So listen, I was in the same camp, but then seeing just the gaps in care. I was like, there's got to be something better. And even if you're able to spend the funds to like do IVF, why should you also have to pay cash pay for the therapy?
Right.
Like, you're paying an insurance premium to your insurance. Like, you deserve to get care from that.
Yes.
That's the point of this, not to have everything live outside of it and have to pay the insurance premiums or the out-of-network costs, which is like, again, it's chasing down the insurance company to see if they're going to approve these costs, and they don't even cover it 100% for most policies.
Yeah, absolutely. So like, how can healthcare providers help support their patients to prevent any sort of re-traumatization or further contributing to trauma? Because I do feel like, especially when I get second and third opinions, not only is there the trauma of the loss, the grief, the infertility, there's also the trauma from dealing with a bad provider.
Oh, I know. This one's hard because I think this one's at the root of like a lot of cultural things as well as our medical education. But my first would be to say so this is for the providers. Every patient is an expert in their body.
Yes. Yeah.
Okay. You're an expert in medical systems and how people work, like, the biology, how different organ systems, how they work in the general population, because you've seen a lot of different patients, but no patient is alike. And I think it's really important that we at least validate, a patient's experience. If a patient tells me they have the oddest, my left pinky tingled when I took this SSRI, I'm going to say, well, tell me more about your left pinky tingling. But you know what most providers would say? Oh, that's not a side effect.
Totally.
That doesn't happen.
Yeah.
And so that's a good example. And it happens a lot in medicine of yes, as a physician, it may not be something you've seen. It may not be something that's in the literature, but it doesn't mean it doesn't exist. And so long for so many women, that's exactly what healthcare has been. It's like, no, I'm having this pain here. Oh no, that type of pain doesn't exist. Well, you know why? Because we didn't learn about it in medical school, because the research probably hasn't been done. But I think this is where we come up with this overused like gaslighting in medicine. Just because we haven't discovered it or totally know everything about women's bodies doesn't mean that they don't kind of, what they're reporting is false.
It's not real.
It's not real. And I think that has been, I can't tell you how many patients have come to me and Mavita Health because this is the experience they get from everything from mental health to OBGYN. And it's just so hard.
So hard. I always try to give the other doctor the benefit of the doubt.
I know,
because
me too.
I always think I wasn't there.
I
don't know what the conversation was. But I think
But you kind of know what the conversation was.
and-
Because you've
and
been
I-
there as a patient, I'm sure.
Yes. And I also think it's really important to just believe the patient. And
listen,
I've even been humbled through the years. I feel like as a resident, I maybe didn't have that level of humility as I do now. And
factitious disorder, Munchausen's, like it happens. And these are when people feign symptoms for secondary gain. It doesn't happen that much.
No.
Like, period. So let's stop thinking
I've
about
never
that.
seen it.
Right, okay.
I've actually never even seen it.
Fair.
So
exactly. So that is so rare. What you have to say is, oh, you have that left pinky pain. I haven't seen that before, but let me be curious about your symptoms. Does this feel something that you could maybe live with? Do we want to see if maybe it goes away in a couple weeks? Or do we want to decrease the dose or change medication for you? You know, that's what I would operate from. Exactly. Instead of and curiosity. Yeah. Always lead with curiosity instead of leading with like, that doesn't happen.
Right.
Or like, I think
fine.
That's fine. You're fine. Right. That kind of stuff. I think it's like, no, how is this impacting you? And I don't know if it's like, I think the insurance system has made, unfortunately, physician working conditions really difficult. So I think people are cynical, a little bit callous, because they are so kind of pushed to see such high volume, and they don't get that quality of care. And so I think it's more systemic. I don't think it's necessarily these people are trying to be, dismissive or these a-holes that they are. But I think what's happening is that they're likely going through a lot of stress.
Yeah.
And when we're really under high stress, when we're burned out at work, we become highly cynical and we stop listening. And I think that's what's happening with these physicians.
Yeah. It's unfortunate.
And older physicians, like a lot of older physicians are leaving practice.
Yes. And I think it's just, the test of time, the longer you've been doing it, the more burnt out you start to feel just because of the whole medical system as a whole.
And the idea that I've seen everything. No, you haven't.
Right.
Like, I don't care if you've seen 20 or 30 patients a day, you have not seen everything.
No.
And so believe people when they tell you what's going on with them. And if not, be curious, because there may be something underneath that left pinky pain. There may be another reason for it, or there may be something else that's happening. And you just asking about it and addressing it is like so important to a patient. That's
Changes
what makes that
experience.
Connection. Exactly.
Yeah.
And you're less likely to be sued. But all you have to do is be nice. That's what doctors don't get. And then they wonder well, this is what happens.
Yeah. Well, I love the conversation that we've had. I love your insight, and I hope that anyone listening to this can feel a little bit less shame about their feelings, their emotions, their mental health. And if you are navigating infertility or loss, please seek the help.
Yes.
I mean, you don't have to suffer in silence, feeling isolated. There is therapy, there's medication, support systems in place that can help you get to where you need.
Absolutely. And I think the other piece that I would love to sort of include is, tracking things I think is really important. What can you do to feel like you're tracking your symptoms? I love Natural Cycles and that app.
Yes.
You can track your emotions. You can track your pain in your body. So you can have all of that, and that's so helpful for doctors.
Yes.
Or if you have insights from someone's cycle when they come to see you.
Yes, I love that.
It's just like, we want that data. If I could know like what's happening in the last month for you, like in terms of your mental health, your sleep, your cycle, I can also make I can have some ideas of what's going on.
Totally.
And so if you have more knowledge about your cycle and your body and what you're experiencing, and you have that data that you can share with your physicians, it's like chef's kiss. That's like the perfect situation where we are like now ahead of the game. Now I have all of that data that can inform decisions that I'm making. I'm sure that's the case with you too.
Absolutely.
Like if you know how many times they've tried or they've been ovulating, and like it just gives you so much more information of like, this is the plan we should take.
Yes, tracking ovulation cycles. It even helps me determine their IVF starts and how to prime them for IVF.
I mean, look at that.
I'm all about this data.
And that's like a nice thing for people to feel like I'm doing something. I think during these process, people feel really out of control. And like, why can't I just do this like everyone else? They're just going home to sleep with their husband and they have a baby. Like, and that to me gives you a tool that's like concrete. And it's like, I'm doing this, I'm getting this data, and I'm contributing to my own health. And this way is also good for the dismissive doctors of like, no, here you go. Like, I haven't had a period in 3 months. Like, this is what's happening, or here I've been having these symptoms. So I think that's helpful, being an advocate for yourself. But ultimately, like, if you don't have a good experience with a doctor, I hope that you can find another.
Yes.
Where you are connected. I think this is so important for IVF because
it's
such an intimate kind of long-term relationship that like if you hate going into the office because you get brushed off.
Find someone else.
Yeah, that's right.
There's plenty of doctors out there. Totally. Well, Dr. Oreck, thank you so much. Yeah. This has been lovely.
That's great.
And where can everyone find you?
So at Sarah Oreck MD on Instagram, also at Mavita Health. And if you're interested in getting care, we are available in California, New York, and New Jersey, covered by Aetna, Cigna, and Blue Cross Blue Shield programs. And you can go to mavitahealth.com and sign up for yourself.
Great. Amazing.
Yeah.